Right, okay, let's just run through these slides. So just going to make a few verbal notes as we go along. So we looked at these rules of thumb and looked at the migraine presentation, framework for migraine presentations, and we're looking at two presentations. A presentation that's complicated, someone just comes in with a headache which is unrelated to their other problems, and a complex multimorbid presentation, and you deal with these in two very different ways. Just to make the point that chronic migraine doesn't come out of anywhere, it builds up over time, low frequency episodic, high frequency episodic, to chronic migraine, which is highly comorbid and invariably associated with medication overuse, headache. And these are some of the migraine comorbidities, which is important to be aware of, because the person with migraine may not realize that this is associated, particularly something like restless leg syndrome, and they can cause quite considerable morbidity. Just to pick up on medication overuse headache, very common, virtually everyone with chronic migraine will have it. Any painkiller, including anti-inflammatories, on 15 days of the month or more, or any triptan on more than 10 days of the month. And just to look out for people with lax joints, we're becoming increasingly aware of them. These are some of the things that they have an increased frequency of, all of which are related to headache. So this is a bit of the outline. It's going to be quite theory heavy. Let's start off with the difference between complicated and complex. So a complicated system is something that you can unfold, whereas a complex system is something that is braided together or entangled. So this is a complicated system. This underpins Western science. We can understand the system by breaking them down into its component parts. There's lots to talk about here. And there's also lots to talk about in complex systems, which you can't break down. And I think these are both very relevant for many systems, including medicine. And if you want any more information, I put a YouTube together about it, which you can look at. This is a model of the consultation that I'm working on, which sees health as reducing the inevitable tendency towards disorder, or the second law of thermodynamics, increasing entropy. And you can break systems. You can describe the domain of the clinical presentation you have and describe it as complicated, complex, or disordered. We're looking at two domains: a complicated domain and a complex domain. The other bit of theory we need to just look at is the difference between homeostatic control, which is reactive control based on negative feedback, keeping an output constant, and the new hypothesis of anticipatory or allostatic control, where the brain makes a prediction of what needs to be done and checks its prediction and monitors for prediction error, and if there is any error, changes the model on which it operates. So it's a very different way of looking at things. I think it's quite an interesting way. So for example, when you go upstairs, I gave an example of the homeostatic model and also the predictive model. We make an idea of what we need to do before we get onto the stairs, and as we go up the stairs, we check our model and see if there is a predictive error, and if there is, we change the model. We also need to look at the stress response. This is quite a sort of evolutionary old response, which is a generic response to many stressors. And here are the elements of it. Quite a complex array of responses. This is the cytokine response. And we discussed in some cases, a lot of people we see in the headache clinic with post-head injury, post-viral injury, long COVID immunization. For some reason, this stress response doesn't return immediately back to normal again. This leads to all sorts of ongoing problems. So let's talk about migraine, and we looked a bit about the evolutionary advantages of a hypervigilant brain, but alas, a million years later, things are not looking too good for a hypervigilant brain. And we have a migraine generator which fires off, presumably aims to reboot an overloaded brain, and this is at the midbrain area, and this has implications for gastric stasis and neck pain. Both of these areas are also in the same area. Then we looked at the migraine journey. For many people, this long and winding road, and we looked at this cycle of seeking help and never finding it. Only 15% of people with migraine actually get optimum care. Migraine number 6 in the world in terms of impact. So let's look at this acute presentation, how we're going to manage it. We've got 3 buttons to press, bearing in mind our International Headache Society classification, and also bearing in mind that in all settings, over 90% of people will have migraine, and in general practices is going to be probably about 95% plus. Going back to our predictive brain, this is our prior probability of what we're going to be seeing, just reflecting the fact that migraine is the most common. Some of the I'm not going to go into all the points in the history, but these are some of the things that I think is quite important to tease out a history of migraine. What you do is always an important question. And then our first examination, in our first 10-minute consultation, just a very brief examination of blood pressure and fundoscopy. And then if you're not clear about a diagnosis, you can undertake a delaying tactic with a diary. Fundoscopy, we said a little bit about. What about red buttons? When do we press a red button? Thunderclap headache, causes of thunderclap headache. This is a headache that reaches its maximum crescendo in 30 seconds. And this is a reversal vasoconstriction syndrome you may not have heard about, and many people haven't because it's only visible on an MR angiogram or a CT angiogram. Watch out for people on SSRIs, high doses particularly, and also recreational drugs, cocaine and cannabis. Temporal arteritis, acute glaucoma, idiopathic intracranial hypertension, and carbon monoxide, always one of these things to have in the back of our mind. So orange buttons, do something within the next couple of weeks. These are the red flags that we're going to be definitely imaging. These are orange flags when we're going to be watching very closely. Go into those, and this is cluster headache, very different from migraine. I think that's an orange button because this needs to be sorted out pretty quickly. It's the most painful condition known to man, and I think it's important to get on top of cluster headache quite quickly. Then once we've done that, we can press the green button and diagnose a primary headache. So let's look at migraine, because this is going to be our default diagnosis. Almost all our acute presentations like this one, having excluded a secondary headache, will be migraine. This is our first stop for the acute attack. Atogepant, the new drugs which we're seeing a little bit more about for 2 triptan failures. I think 3 triptan failures is a better one. 3 soluble aspirin, 3 soluble paracetamol is a good starting point. You've got to get up to blood levels quickly. Always use a prokinetic, metoclopramide or prochlorperazine. Other stuff you can do from a preventative perspective. The party line is 3 of propranolol, amitriptyline, topiramate, candesartan, although topiramate for women of childbearing age will be gone quite soon because that's going to be on a pregnancy prevent program. So you have to try 3 preventers of those traditional ones, all found by chance, before you move on to other medications, which will include Botox for chronic migraine, or more and more now the CGRP antagonists. This is the big new group of drugs that we've had introduced into practice and made a very significant difference. This was the first generation of monoclonal antibodies, injectable. Patients give themselves an injection once every month, specialist initiation. But the important development has been the oral GPANTs. Things are a bit confusing at the moment because the market is yet to settle down. But certainly atogepant looks like it's going to be available for both chronic and episodic migraine, and probably going to be initiated by GP. So I think rimagepant's going to have to change itself a little bit, but these drugs are going to revolutionize the management and prevention of migraine. They have very low side effects. They are quite expensive, although with time the price will come down. These are going to be GP initiated drugs, and there's no reason why they shouldn't be first line of management. Other things we can do, So you are unable to make a diagnosis at a month. You haven't been able to diagnose migraine and go down that pathway. So they come back in 4 weeks, repeat the 3-minute examination again. There's a very good YouTube by Charles Ellington on how to do that. And you can do another delaying tactic, take some routine bloods. I mean, I think everyone's happy that something's been done. The chance of you turning up something that will be impacting the headache will be minimal, but it's something that is not unreasonable to do, and ask them to come back in another 4 weeks. You're waiting for a phenotype to emerge. So come back at 8 weeks, repeat the examination, don't do any more blood tests looking for things like anticardiolipin antibodies unless they are clinically relevant, clinically obvious. Then at this stage you can discuss imaging with the person, or if you're unclear about what to do next or a diagnosis, you can consider referral. So that's a brief introduction to how you can do an initial presentation in a maximum of 3 10-minute consultations spread over a period of 8 weeks. So what about our complex problem? So you have a very different approach to this, and briefly, the consultation is now a therapeutic one rather than a diagnostic and management one. The most important thing you can do is to take the patient seriously and listen to them and give them a story that is meaningful to them. So the other issue is to make it clear that we're after control and not cure. Unpack the headache. How many types of headache do you get? These people will always have more than one type of headache, and this is often leads to confusion. There will be definitely medication overuse headache. There will be chronic migraine, and invariably with chronic migraine comes idiopathic stabbing headache, some jabs and jolts, and often a dull background headache, which you can certainly diagnose as a tension type headache, but it's probably easier just to scoop the whole lot into medication overuse headache and a migraine type spectrum. So you can treat the migraine. Explore multimorbidities and treat them appropriately medically if you can. But the next big question to go on to, and you're doing this in steps of 10 minutes, you're not going to do all this in one thought, perhaps you can get them back for double appointments, to start teasing out psychosocial issues and give them a story that makes sense. And we can go back to the story of the chronic inflammatory load building up, which I think is a useful one. And we talked about how migraine and all these other things are significant stressors that impact upon our inflammatory load, which is held across the body, not just in the brain. All these other environmental things like obesity, gut biome are prokinetic, processed food, all prokinetic. Adverse child events we're more and more aware of. Obviously, it looks like they're part of the norm, really, and this interesting concept of intergenerational trauma as well. So this is probably all feeding into this. So easier said than done. What you do about it? Well, you can refer them to your local psychological therapy, but we take a slightly different approach, just to say that as the chronic inflammatory load builds up, you get impact upon your predictive brain modeling, and also, interestingly, this chronic inflammatory load seems to act epigenetically, and this, because the brain is unable to resolve a predictive error, turns up the modulation of your interoceptive and exteroceptive signaling, giving rise to all these other problems like irritable bowel syndrome, fibromyalgia. So it's quite a neat hypothesis, this actually. So I'm very much focusing on holistic care as the next step, and hopefully putting together a manual that will be available to people to use, working with a colleague of mine who's a Reiki healer, holistic healer, healing, facilitating the body's ability to heal itself. And this is nothing sort of magical, or because all you've got to do is look at the huge placebo effect in particularly migraine and other painful conditions. So this is a recent meta-analysis looking at all the CGRP drugs, and 66% of these drugs in trials are placebo benefit. So here's Rimagepant, our CGRP drug, and Gepant, 49% drug reduction, 41% placebo reduction. So what we're saying is, hang on a sec, what's going on in this placebo effect, and how can we utilize it to complement the action of the drug? And this is our holistic approach. based on 3 pillars underpinned by a reframing of the sense of self, medical approach, creating a favourable environment, and mind, body and somatic techniques. This obviously takes time, but we are shifting, and we're not saying we're not using drugs or we're not using medical approaches, we're using a 2-track approach, both of which have very different models, and here are the approaches and the differences between the 2 models that we are using, or the 2 columns that we are using, 2 tracks we're using. And these are sort of questions that we would start thinking about. These are some of the somatic techniques that we might be using, the mind-body techniques, underpinned by the fact that the mind and body are seen as one unit, and the body often holds the stress, the body keeps the score. And you can actually map this quite nicely onto how these holistic interventions are benefiting the predictive brain model.